So welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Please note for the record, Dr. Michelle Morse is representing Dr. Dave Shuxley, Scott French representing Stephen Banks, and Dr. William Fisher representing Dr. Michael McRae, and Philip Wadley is representing Deputy Mayor Melanie Hartzog, all in a voting capacity. So next on the agenda is the adoption of the minutes for the board meeting held November 18th, 2021. Are there any questions or suggested changes? So can I hear a motion to accept this minutes?
So moved.
So let me get your votes one by one. Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Morse,
Yes.
Dr. Fisher,
Yes.
Philip Wadley,
Yes.
Scott French,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Piñeiro,
Yes.
Frida Wan,
Yes.
Anita Kawatra,
Yes.
and Jose Pagan, yes. So the minutes have been approved. During the executive session, the board received and approved oral and written governing body submissions from NYCH and H Bellevue. The board received and approved semi-annual governing body reports. These are written submissions from NYC Health and Hospitals Jacoby and North Central Bronx. So let me say thank you, Ms. Hernandez Piñeiro, for participating in the Joint Commission survey at Lincoln Hospital in the leadership session on December 3rd. Would you like to provide any feedback?
I think it was a fascinating session. I got to sit in on their sort of formal feedback session before they had a more open discussion. And the depth of granular detail that's in the questions they ask is, I think, what surprised me the most. I mean, it's really, really very detailed questions, and the Lincoln staff did a tremendous job. And then we had the more open question, and as one of the member of the team said, I'm a white woman from the Midwest, and I'm here to rate you. And so they were very candid about how different Lincoln is, and Health and Hospitals is, from many, if not most, of the hospitals that they audit, but how incredibly impressed they were by the close teamwork between all of the different health parties, and how evident was that the patient was at the center of everything they did. They were just extremely complimentary about Chris and the whole, and everyone they interacted with. So it was my first time, and it was a great experience.
That's great. I'm glad that they did well, of course, and also that you were there to support them. So I'm sure they really appreciate it. Thank you so much. So another item on behalf of the board, I would like to congratulate Dr. Katz as the recipient of the 2021 Preston Robert Tisch Award for Civil Leadership, presented by the Aspen Institute. We should clap or something. The Preston Robert Tisch Award. Yeah, the Preston Robert Tisch Award is awarded each year to an individual who has had a positive impact on their community, who embodies the broad Aspen Institute idea of values-based leadership, and who has exemplified this idea in innovative ways that can serve as models for other leaders. This award was well-deserved, and we are very proud to have here our leader, Dr. Katz. Thank you.
Thank you. Thank you.
Okay, VENDEC approvals. Since we began the process of approving contracts prior to VENDEX approvals, there are 16 items on today's agenda requiring VENDEX approval, of which 14 have that approval. There are 8 items from previous board meetings pending VENDEX approval. Since we last met, no approvals were received. We will continue to notify the board as outstanding VENDEX approvals are received. Next, we move to a T2 update. So let's move now to the resolutions.
Item 6, yes.
Number 6.
Number 6, item number 6. I'm sorry. Yeah, go ahead.
Oh, I did it.
No, I read that one. I'm sorry. Okay. So item number 6 on the agenda is an amended from the Capital Committee approval to change scope from data closet upgrade to intermediate distribution frame. And the resolution is authorizing the New York City Health and Hospitals Corporation to execute a contract with Gemco Electrical Contractors, Inc., the contractor, for an amount not to exceed $7,224,156 for construction services necessary for the main distribution frame upgrade and intermediate distribution frame phase 2 at NYC Health and Hospitals Harlem Hospital, with a 10% project contingency of $723,416 for unexpected changes in scope, yielding a total authorized expenditure of $7,957,572. And this was presented to the Capital Committee on December 7th of this year. Christine?
Thank you so much. I'm joined today by Dr. Eric Way, our acting CEO at Harlem Hospital. Eric, are you there?
I'm here. Hi, everyone.
So we'll go ahead and start on the first slide to do an overview of the project need at the facility. Can you move back up?
Okay, so I'm so glad that we added Kim here to correct anything that I say wrong on this. I asked Christine yesterday what MDF and IDF stand for, so I'm glad it's written out here. Otherwise, Mitch would, chastise me for using acronyms that I don't know what they stand for. So it's not a data center. That's what I learned from last time. But we have IT equipment in closets that were in the Women's Pavilion building that is being currently demolished to build a new public health lab. And so we need to move this IT equipment into Mural Pavilion as well as MLK to existing buildings. And they need their power and AC units to be upgraded so that the equipment has power and doesn't overheat. And so it's to allow us to continue to have required IT equipment here at Harlem Hospital to keep everything going. So I'm going to turn it over to Kim to actually use the technical terms.
Okay, well, as with many projects at OFD and EITS, we align and we collaborate on our strategies. And our basic premise at the local or facility-based network is to provide a stable, reliable, and redundant network with sufficient bandwidth to have the connectivity to all of our applications and services located at the data center, at the corporate data center. And we'll make that distinction, the corporate data center. So the requirements, the second bullet here is that at each facility, we have 2 MDFs or main distribution frames to provide that redundant connectivity. So in those closets that Eric referred to is our ability to connect. And if you look at the right-hand side here, I can talk a little bit about the intermediate distribution frame as well. So that is the connectivity that comes from all of our devices. So that could be our handheld devices, our PCs, and then that goes over to the mainframe distribution framework, which then from the mainframe goes to our corporate data center. So our data center transition, our migration that we are working on now, that we've had board approval for before, is a separate and distinct project from this. So at each facility, and we do have redundancy at the facility, we have 2 main distribution frames or 2 MDFs. I'm getting tongue-tied myself, right? To provide that redundant connectivity for the facility to the corporate data center. In addition, each floor has those, as you might imagine, those intermediate distribution frames, they're also commonly called the IT closet, that takes the information from the devices to the mainframe to the corporate data center. So they are separate and distinct, but they are aligned, with the strategy as we're building these new buildings and making sure that we have the connectivity that we need to support our end users, which are our providers of patient care. Christine?
Thank you so much. So after this overview of the assignment at hand, which required substantial infrastructure to support this EITS strategy, could we go to the next slide, please? Thank you. We had sourced via public bid a construction contract to provide this electrical and infrastructure to support the IDF and MDF infrastructure needed at Harlem. And Gemco Electric Contractors was the lowest of 3 bidders for this project. They had an MWBE subcontractor utilization plan of over 36%. The subconsultant plan is listed below, and the contract amount, as indicated in the resolution, is $7,234,156. And they're currently one of our JOCS contractors, and they've been a prior JOCS contractor as well. Their evaluations have been very positive for our system. They continue to serve our system on many fronts, rated 93% and 93% respectively. And they also have ratings within the Passport MOC system of 3 excellent and 4 good. This project is with board approval after contract registration is expected to be completed in 2023 after NTP. The next slide is the actual budget for the project of 7.9 million total that the resolution provides that authorization for, which allows us to have a 10% contingency. The next slide is the resolution that Chair Pagan, you read already into the record, and we're happy to take any questions as a team.
Any questions from board members?
Very quick question. The old MDF was 3,280 square feet, and the new one is 784, plus about 7.2 million. Is that because the equipment is so much smaller or more efficient now? Is the cost comparable to what was before?
If I could jump in, so Jeff Lutz, Chief Technology Officer, correct. You know, a lot the smaller footprints is that the equipment is smaller these days, much more also better with heat efficiency and the like. But yeah, much more smaller, much compact. And part of the data center project that we've had in the past was relocating equipment that was there into the data center that needs to be in the data center. So we've also reduced our footprint size there.
Thank you.
Okay, so let me then ask for a vote on this. Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Morse,
Yes.
Dr. Fisher,
Yes.
Philip Wadley,
Yes.
Scott French,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro,
Yes.
Frida Wan,
Yes.
Anita Kawatra,
Yes.
and Jose Pagan, yes. So the resolution passes. Let's move. Thank you so much.
Thank you.
Let's move to the next one, which is item number 2 in the agenda. This one. You read it.
I think before we read the first resolution,
Oh,
Ted and John are gonna
Okay,
give a
so
quick,
Q2 update.
Okay.
Go ahead.
Yeah, so this is a slide that was in the finance committee deck, really outlining, the spending that's taking place within the T2 program. And as you can see, it's bottom line, it's $1.4 billion, growing to $1.5 billion. And there's modifications to the numbers, obviously, as we as we change our response. But as we've talked about, is that working very well with City OMB and the other stakeholder agencies to work out the money, and we have the MOU as our ultimate backstop here. So we just want to make sure that you had a chance to kind of look at the numbers. They're lined out between testing and tracing, and there was modifications that have been made really again to respond to the needs of the community. So we just want to make sure that you saw these numbers, knew that we had them well in hand. We monitored them very closely between our two teams, and we're comfortable with spending that we're doing, and we have to do it. So,
and I can quickly just highlight very quickly some of the key findings here. So testing wise, health and hospitals and T2 have done more than 7.3 million, it's actually 7.4 million tests, million PCR tests. It was unfathomable, back in March and April of 2020. So we've come so far. From a contact tracing perspective, we're reaching a higher proportion of new cases than any other city in the country. And we've identified 1.3 million close contacts or people with an exposure to the highest risk of developing COVID and therefore infecting others. And we're able to help them to break chains of transmission and help them to quarantine. On our Take Care side, we've completed 322,000 resource navigation referrals for things like Get Food, which we talked about before, and for our free food delivery service, and more than 26,000 hotel guests. On the vaccine effort, we run 3 mass vaccination sites, and we run the program that delivers the vaccine through your doorstep, which is available to any New Yorker in New York City. So these accomplishments of the program, I think, have been really important to keeping our city safe during COVID. We want to continue to do it as we are entering this 4th wave now.
Okay,
Thank you.
thank you so much for the update.
Sure. Thanks.
Thank
So
you.
let me move on then to item number 2 on the agenda, resolutions. So
Okay, thank you. I think that the next couple are related to T2, so that update was very helpful, John and Ted. So number 2, authorizing the New York City Health and Hospitals Corporation, the system, to sign a 2-year contract with Rapid Reliable Testing New York, LLC, the vendor, to operate, maintain, and supply mobile healthcare units to provide primary care services to homeless individuals living on the street through its Street Health Outreach and Wellness Show program, with 2 one-year options to renew that can be exercised only by the system at a cost not to exceed $21,806,323 over the potential 4-year term. This was presented to Finance Committee on December 7th, 2021, and approved to bring forward to the board.
Great. All right. Well, thank you for having me today. So first resolution. So we started our street health outreach and wellness units as part of our COVID fight against COVID. We had this problem, which is where our homeless individuals in New York City that were living on the street were some of the hardest people that were to engage and to get them vaccinated. And we came into it with a hypothesis early on that if we were to offer them services that they would find valuable, wound care, other primary care oriented services, that would be a way for us to really have the conversation about delivering the vaccine to them. And we really hit a nerve in terms of, I think, the opportunity here. And we ended up, we've been able to help 80,000 people as part of this program so far, done thousands of vaccines, many of which are among our hardest to reach populations across New York City are homeless people that are living on the street. So we wanted to take a lot of those same principles and really build it into rising from a test and trace activity to something that would be woven into the fabric of what we do at health and hospitals as part of primary care moving forward. As everybody knows, homeless people lack reliable access to healthcare, exacerbating negative health outcomes. I shared a little bit about the initial contention of the show model, which is where we did wound dressings, evaluation of symptoms, even gave snacks, hygiene, and we built in a strong behavioral health component of that over time. We currently operate 6 units under the emergency declaration, which is focused on the fight against COVID among these very vulnerable populations. One challenge is to flag is that the vendor currently has their own EMR, but part of this, as we want to bring it in-house, in terms of the clinical side, we'd be using our own EMR to really provide seamless care to our hospitals and other clinics. So next slide, please. So in terms of the background and current state, what we want to do is right now, the current state is we have staff that go out and provide these services to people that are homeless living on the street. In our future state, we want to actually have New York City Health and Hospitals provide the clinical services, with this proposal here being to have a vendor provide the vehicles. So something that we're not renowned experts in, but clinically, I think we really are the renowned experts. So sort of bringing together the best of both worlds there. This would be an ambulatory care program. It would be connected to our primary care safety net clinics at our hospitals, which one fun fact about them is they've been able to achieve better diabetes control among diabetic homeless patients than the diabetics in the rest of our whole system. So these are extremely effective clinical models, and this will be the connection point to bring more people into them. The staffing model that we want to really continue to work through, but this would be sort of a first attempt at how we'd want to structure it. It would be a provider, a PCA, behavioral health team, a nurse, clerical, a community health worker. And then I also just wanted to highlight that behavioral health will be a really important intervention and focus for especially this population. So we'll have addiction counselors, peer counselors, social workers, connections to dedicated psychiatry in our existing clinics, our existing primary care safety net clinics, and even telehealth so that we don't miss a beat if we have the opportunity to make an intervention with somebody that is literally on the street. Next slide, please. So in terms of procurement, in October, we put out the RFP on city record. It was sent directly to 29 vendors. On the 28th of October, we held a pre-proposal conference. 8 vendors attended. 8th of November was the deadline. We received 3. 17th of November, clarifying questions were sent. On the 18th, the vendors completed them. And on the 19th, the evaluation committee completed scoring, and Rapid Reliable Testing LLC was the highest rated proposer. Next slide, please. In terms of this proposer, this is RRT is a subsidiary of DocGo. They operate doing medical transportation and ambulance-based services really across the globe, including the United Kingdom. So they have a lot of experience. They have experience doing on-site medical services as well, operating vehicles like we'd asked them to do as part of this proposal. And the relevant New York City experience is they're one of our testing vendors. They perform nearly over 600,000 tests to date. And also they do mobile vaccinations as well, over 150,000 COVID-19 vaccinations to date. Next slide, please. So the RFP criteria, minimum criteria included prior experience, providing a client with at least 5 vehicles for mobile medical clinics, prior experience in maintaining and operating vehicles, MWB utilization plan waiver or certification. Substantive criteria were 30% cost, 20% relevant experience, 20% service standards, 10% ability to scale, and 10% MWBE. Evaluation committee was comprised of our deputy COO of AmCare, director of implementation AmCare. We have our care models team, our corporate budget and finance, Office of Behavioral Health, pharmacy, primary care safety net, Lincoln Hospital Behavioral Health, Woodhull, and OFD. Next slide, please. So in terms of MWBE, we list here the number invited, number responded, and then underneath for Rapid Reliable, the goal, Rapid Reliable has agreed to a 30% goal, and it's split as we have in the second table here between 3 certified MWBEs, 5%, 15%, and 10%, totaling 30%. Next slide, please. So we're here seeking the approval of the board of directors to award a contract to Rapid Reliable Testing for providing the vehicles, operating and maintaining the vehicles, and supplying and stocking the vehicles for the Street Health Outreach and Wellness Program, or SHOP, for $21,206,323 over the potential 4 years. 2-year contract with 2 one-year renewal options at the discretion of H&H. Additional funding from the city is required for the H&H staffing costs, which I went over with the staffing model. And then here we have the program expenses at the bottom. I'd be very happy to answer any more questions.
Thank you, Dr. Long.
Dr. Wines, well, it's actually more of a clarification, because
Sure.
I did mention that these were T2 resolutions, but while Rapid Reliable was operating under T2 before, this new resolution is not going to be part of T2. Is that correct?
Correct. So it's a perfect example of some of the innovation we create under T2 that we want to draw best practices from to really change the way that we deliver healthcare in our system moving forward.
So I think this is terrific, and the statistic you provided regarding diabetes is very impressive. And I think these models that we've learned, that we can adapt to, maybe the silver linings of our COVID experience.
Agreed.
Thank you.
This little clinical care group, like traveling clinic you're putting together.
Yeah.
What kind of vehicle will they be traveling in?
Well, this is the
I know it's the kind. Is it a minivan, an ambulance?
I think it's technically a mini bus, although I'll see if Chris wants to correct me.
Mini bus?
Mini bus. Don't exactly.
Oh, okay, all right. No, I'm just, because it's a group, quite a group of people you're assembling.
Yeah.
Okay.
It's like a small bus.
Thank you. Any other questions? Okay, so let's have a vote on this. Dr. Katz?
Yes.
Thank you. Dr. Calamia?
Yes.
Thank you. Dr. Morse?
Yes.
Dr. Fisher?
Yes.
Mr. Wadley?
Yes.
Mr. French?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Frida Juan?
Yes.
Anita Kawatra?
Yes.
And Jose Pagan, yes. Thank you. So resolution has passed. Thank you so much.
Thank
Dr.
you.
Long. I look forward to hearing more about the details that you mentioned on diabetes control and so on. So the next one, Frida?
Next one, sorry. authorizing the New York City Health and Hospitals Corporation, the system, to increase the funding for the 12 vendors listed in Annex A attached to this resolution, each a vendor, and together the vendors, from the $250,480,410 set in July 2021, when the Board of Directors authorized contracts for the vendors to perform COVID testing both in schools and in the community on an as-needed basis, by $205 million to bring the total amount for all vendors to a new amount not to exceed $455,562,279. This was also presented to and approved by the Finance Committee on December 7th, 2021 to bring to the board today.
All right. So for background here, our ability to do testing in New York City has been one of the cornerstones of our fight against COVID. It's one of the pillars of our overall surveillance system and gives us the line of sight that we need to know what's going on with case transmission and where there are contacts so that we can help them to quarantine to break chains of transmission. We brought a proposal to the board in June of 2021 where we conducted an RFP to include school testing and community testing. At that time, testing was in all of New York City's public schools on a routine basis, conducted by the vendors listed here, and community testing, we were doing testing at home, saliva, employee testing mandates, with the vendors listed here as well, was well under bullet point 2. In July 2021, when the not to exceed was approved, since then testing policies have changed, and this is part of the evolution of the virus. In particular, on the school side, we went from monthly testing to weekly testing, and there was a court decision that other schools, non-public and charter schools, would be included in the same type of program being provided to our public DOE schools in New York City. And then on the community testing side, we've had more support for the New York City employee testing mandate, uptick in community testing volume, which we're seeing very strongly right now as we are in our 4th wave, and deploying mobile testing to backfill decommissioned brick and mortar sites, which we've done over time to make sure that any community that's had a brick and mortar site never has continuous testing availability in their community. We'd never want to take that away. So in doing all of that, we're on a trajectory to surpass the initial not to exceed that we came to the board with before. So we're seeking to increase our not to exceed from 250 million. 480,410 to 455,562,279 through June of 2022. This would be an increase of 205 million. Of note, the vendors have been all performing satisfactorily. So, and to go into a little bit of detail for schools and community testing. So the changes that I mentioned in the schools resulted in increasing our universe by 420,000 monthly. This was non-public charter schools added 120,000 students to the testing population. Also going from monthly to weekly testing went from 100,000 tests per month to 400,000 per month, so times 4. And the average monthly spend of 30 million from August 2021 to June 2022 for a total of 334 million. On the community testing side, we adding our capacity, we went from a capacity of 7,000 to 45,000 tests per month by December. This is important because, again, New Yorkers, as I like to say, vote with their feet, and people are coming out in droves now to get tested, and we want to be there to help them to get tested. They've made the small sacrifice to come out. We want to be able to deliver so that they can make the decision to keep their families and communities safe. We've also built out our other models first to further support the testing that people want in our communities, and that includes saliva testing with a capacity of 9,000 tests per month. We've replaced certain brick and mortar sites where we have had to leave, for example, because one of them wanted to build a school. So better to allow that site to build a school, and then we can still offer testing seamlessly to the community by bringing in a mobile unit. So you get a win-win there. And that's mobile capacity to ability to ramp to as many as 130,000 tests per month, or ramp down with respect to how we were replacing our brick and mortar sites. For an average monthly spend here of $11 million from, again, August 2021 to June 2022 for a total of 122 million. So these programmatic changes are require an increase from the NTE, again, of 205 million to get us through June of 2022 with where things currently stand today. So community impact, we actually developed the random sample method that is the surveillance method for testing in schools that now CDC has as their guidance. That's the guidance for the whole country. We developed this early on when we became the first big city, the only big city in the whole country to reopen our schools. We proved we could keep our kids safe. And actually, when we studied it last year through this random sample surveillance methodology that we developed here in New York City that has since become the standard, we found that students and teachers in remote learning were as likely, if not more likely, to get COVID than students and teachers that were in school. So this not only is a preventive element to it, but it enables us to really have a great line of sight about what's going on in our schools, and proving how safe our schools are, maybe even safer than not being in school, enabled us to bring more kids back into school. And I think that is just such an important thing. We've done nearly 2 million tests since October of 2020. Our positivity rate has been consistently low, less than 1%, which is still true today. We're the largest school district that, again, was initially open and has remained open. For mobile testing, so we have 50 plus mobile units deployed daily, conducting thousands of tests. We have a community-driven model, which I think is important to note, where we bring our mobile units, which can go anywhere, where our community-based organizations, community leaders tell us that there's testing needed the most. So I would say our community-based organizations are the backbone of testing, in the sense that they direct us everywhere we go. And that's, I think, how we've been so successful of doing more per capita testing in New York City than almost any other country in the world. So projected spend and not to exceed requests. So again, in July, it was $250 million over 11 months. As of November 17th, the actual spend has been 14 million, but we've incurred costs closer to 75. And we expect to be exhausted of the current NTE by the end of February 2022. So a matter of months from now. Our testing programs continue to ramp up, and today I think we've ramped up significantly more. One important statistic is our mobile units today, actually yesterday rather, did basically double the amount of tests in a given day than we'd ever done before in our mobile units. So that just, I give credit to New Yorkers for that. We just want to be there to bring people testing, but people want to come out to keep their communities safe, and we want to keep being there for New York City. So, where was I? So requesting $205 million for expansion of the not to exceed to a total of $455 million, 562, 279. Of note, most of this money is actually going towards our DOE testing, and a relatively smaller amounts going to continuing and building our mobile testing that we're doing today. So here's a comprehensive slide listing vendor performance, and just to walk through the columns here. So we have our MWBE goal. We have the percent utilization to date. We have a few notes, for example, on one vendor having MWBE certification still pending. And we have the number of tests by vendor, turnaround time in less than 24 hours. And we break it down by community teams and school teams. Other factors that go into how we use our vendors in terms of implementing them operationally on the ground include things like the ability to scale quickly, the timeliness of arrival at sites, effective cooperation with host partners and schools, timely patient result notification, and patient satisfaction and resolution of complaints. And so that's indicative of the numbers you see here in terms of their performance so far. But this is something we keep a very close eye on, and we adjust how we work with our vendors based on their continued performance in all those categories. So we are here for a request to increase our not to exceed. School and community testing are, again, our critical components of our fight against COVID. Right now, we have our not to exceed of 250 million. We will near this not to exceed by the end of February. Therefore, wanted to come as soon as we could, knowing the direction things are going to the board today, to ask for 205 million in additional funds through FY22. This increase is covered by the T2 MOU between OMB and Health and Hospitals, and I'd love to answer any questions.
Thank you, Dr. Long. That was
I'm gonna try to talk as fast as Ted.
Right.
Okay, I just wanted to say, it's interesting, because you said you doubled the number of tests that were done. And these are in communities that historically have been resistant to vaccination. And I would think that testing, and once you've got an outcome on the test, at least makes it possible that more of these individuals will end up getting vaccinated, right?
That's exactly right. The way I see it is, when you get tested, there's a lot of things that happen after that. If you're positive, we call you and offer even to do a vaccine for you at home when you're done with your isolation period. We get contacts from you, we offer other resources to you, but it brokers that conversation about the vaccine again, to your point.
Yeah.
So the act of getting tested unlocks so many different doors, and that's why it's so critically important.
Thank you.
Any other questions for Dr. Long? Okay, so let's vote on the resolution. So Dr. Katz? Yes.
Yes.
Dr. Calamia?
I think about it.
Yes
Dr.
for me.
Calamia? Okay, thank
Yes.
you. Dr. Morse?
Yes.
Dr. Fisher?
Yes.
Philip?
Yes.
Motley? Scott French?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Frida Wang?
Yes.
Anita Kawatra? Anita? And Jose Pagan, yes. So the resolution has been approved. Thank you so much.
Thank you.
Dr. Long. So the next one is number 4 on the agenda.
Oh, I have to read again, sorry.
Yeah.
Authorizing New York City Health and Hospitals Corporation, the system, to assume requirements contracts with each of Bronx Works, the Chinese American Planning Council, Inc., and the City University of New York Graduate School of Public Health and Health Policy, the agency, from the Housing Recovery Operations Unit of the New York City Mayor's Office, HRO, to provide client engagement services in connection with the Test and Trace Resource Navigator Program, RNAV, and the Aftercare Program, ANAV, for the period January 1, 2022 through June 30th, 2022, for an amount for all 3 agencies not to exceed $17,723,816. This was presented to Finance Committee on December 7th, 2021, and approved to bring forward to the full board. Dr. Johnson.
Thank you. So I'm Amanda Johnson. I'm a primary care internist, and I work with Dr. Long in our Office of Ambulatory Care and Population Health, and I also serve as the director of the Take Care pillar of the Test and Trace Corps. This is the arm of our program that's responsible for providing supports for isolation and quarantine. And very core to this is our resource navigation program, because it allows people who choose to isolate or quarantine at home to have all the services that they need. At the outset of the Test and Trace Corps back in June of 2020, we were facing many different competing challenges. One of the ways in which we were able to bring this program to fruition in such a short period of time was the HRO was directed by the Mayor's Office to conduct an emergency procurement process to find and identify the CBOs that would be able to deliver the resource navigation process. They were selected based on their experience with disaster mitigation and response, their previous existing relationships with CBOs. And just to call out, H&H was not the best organization to take this on directly, just given our responsibility for really responding to the medical crisis that we were facing as a city during the outset of the pandemic. HRO solicited vendors who would be responsible for hiring, managing, coordinating, training, and other services related to managing the staff and delivering this program. Next slide. That committee evaluated the 11 respondents to that emergency procurement request based on the nature of their community relationships, costs, timing of resource availability, and their ability to cover all zip codes of New York City. That evaluation resulted in 6 agencies and CBOs who would take on these contracts through December 31st of 2020, and those 6 are listed there. In July of 2021, we retroactively extended coverage of those 5 of those 6 agreements to cover that January to June period. The decision at that time was that we would retain JCC through the end of the calendar year, and the plan was to retain 4 vendors through June 30th of 2022. Next slide. In the fall, however, HRO was directed to refocus its efforts on the response needed for New York was affected by Hurricane Ida, which left them unable to administer the Resource Navigator program to the same degree that they were able to previously in our pandemic response. To be able to continue this very vital part of allowing for isolation and quarantine, those 3 contracts need to be reassigned to H&H so that we can continue this program without interruption. I will note that we're only continuing 3 of those contracts because, as noted before, JCC will end on December 31st. And then due to the reduction in cases that we saw previously in this year, we were able to narrow it down to 3, and Briceboro will end on December 31st. We do have sufficient capacity with our 3 remaining CBOs to cover all zip codes, as noted in the third bullet there, with administrative simplicity, given that we only have to interface with 3 sets of program leadership. So in terms of the performance of those 3 organizations, they've all met our benchmark of conducting at least or reaching 90 to 95% of our referrals within 24 hours. I'll note that Bronx Works, though performing at 90%, still meets the requirement, and in the last 30 days, their performance has risen to 94 to 96%, commensurate with the other 2 organizations that we're continuing with. All of these agreements are terminable at will, according to Appendix A and these relevant sections of their contracts. And while that's subject to the same MWBE requirements as some of our private vendors, we did want to share some information about the linguistic diversity as well as the gender and racial ethnic makeup of the staff and their boards. And while CUNY did not respond to the diversity request, their language capacity also allows us to serve additional Romance language as well as languages of Zambia. So really being able to meet the full needs of our New Yorkers. Next slide. And so because of this ongoing need for supports for isolation and quarantine in the home, and the fact that the T2 leadership and the Test and Trace Corps are the most appropriate agency for taking on these needs, we would like to bring these contracts into our portfolio. They're a complement to our other take care initiatives, which include emergency food delivery, hotel isolation, take care packages. But all of those contracts are separate and have their own funding streams. Last slide, second to last. We have before you the full amounts for that January to June period for which we'd be assuming responsibility, as well as the staffing levels for the 3 CBOs. Then, in summary, we'll be seeking your approval to accept these assignment of these Resource Navigator contracts for an NTE of $17,273,816 from January 1st through June 30th of 2022.
Thank you. Any questions?
I
Yes,
have,
please.
so when HRO was managing the program, it was part of Take Care basically still, right? And so what was H&H and T2 staff kind of coordinating? I mean, are we taking this on brand new in January? We already kind of
We've worked very, very close with HR leadership from the onset of the program, and so have been very involved in building relationships with those CBOs, so this transition will not be too disruptive to their operation, and helping to plan in terms of their budget needs for the coming year, helping to build out the suite of services that we're able to offer and working to fill those gaps. It has been a true collaboration from the very beginning.
Okay, and then in terms of staffing, are we going to need to staff up now additionally to take this on? And is that covered in the MOU as well with OMB? How is that funded? Because the 17 million is just the contracts for the 3 agencies.
So as it stands right now, with the complement we have, we would be able to take on about 200 additional referrals per day. And so we do still, even at this heightened level of demand for resources, have quite a bit of buffer. There are other aspects of the program that allow us to make the most of the staff that we have without having to necessarily extend the contracts. You're able to bring people back from the field, so the folks that are staffing these mobile sites, onto the phones to be able to respond to those requests within 24 hours. And then we also have aftercare navigators, which are reaching out to people who may have long COVID, but are capable of doing those same resources. If we needed to augment our staff, we are able to do so, but we understand that we need to be good stewards of city resources. And this is accounted for in the 17.2 that we've outlined here.
So I think what I'm hearing is you have some flexibility in the T2 organization, depending on where need is and where we are in the pandemic, and to be able to manage any incremental H&H/T2 staff that we need to manage these within the dollars. And I thought I had one more question. Anyway, thank you for also adding some of the additional information that was discussed. It's very helpful.
Any other questions from board members? Okay, so let's take a vote. Dr. Katz,
Yes.
Vincent Calamia,
Yes.
Dr. Michelle Morse,
Yes.
Dr. William Fisher,
Yes.
Philip Wadley,
Yes.
Scott French,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro,
Yes.
Frida Wang,
Yes.
Anita Kawatra, and Jose Pagan, yes. So resolution approved. Thank you so much, Dr. Johnson.
Dr.
Thank you,
Johnson,
Dr.
you made commercials, didn't you?
I was.
Yes.
that person.
Okay, and you were in, it was my wife, myself, and you for like 6 months. And we welcomed you into our house, and Susan said, well, you're down there, you're a big shot supposedly. Are we on? I said, do you know? I said, I haven't met her yet. So I'm delighted to meet you. Thank you for the great job. They should put you back on. You were good.
Oh, thank you.
Take care.
Okay, thank you so much. Resolution, then let's move to item number 5 on the agenda. It's authorizing New York City Health and Hospitals Corporation, the system, to execute agreements for license renewals for the use of space at the 3 mass COVID-19 vaccination/testing sites, the 12 pop-up COVID testing sites, and the 1 storage site listed in Annex A attached to this resolution. And through an agreement with NYCHA, various locations of NYCHA property for no longer than 1 year for a cumulative amount not to exceed 4.4 million plus an 11% contingency of 500,000 to cover site repairs and utility overages for a total of $4.9 million. This was presented to the Capital Committee on December 7th, 2021.
Okay. So to dive in, so I'm going to talk about our mass vaccination sites, our testing sites, our storage facility, and our agreement with NYCHA. So starting with our mass vaccination sites. So really from the beginning of the vaccine efforts, T2 wanted to help New Yorkers by opening the first 24/7 vaccination sites. And I remember part of my motivation had been, I have patients in the Bronx that work at night, and they told me, Dr. Long, I would only be able to get vaccinated at night. I said, we should open at night. And actually, so these 3 sites have been 24/7 since their inception almost a year ago now. They're still 24/7. So at our site in the Bronx, I recently brought my wife in the evening. Great experience. Didn't have any wait time at all. So these sites are really important to our communities and have done a tremendous number of vaccinations. So in total, the 3 sites have administered more than 450,000 vaccinations. Citi Field in particular in Queens has far and away done the most vaccinations of any site in New York City. It's still going today, and it's still 24/7. So the 3 sites are Brooklyn Army Terminal on the left-hand side, in Brooklyn, Bathgate in the middle here, in the Bronx, of course, and then Citi Field in Queens. The sites will be maintained for up to a year as necessary. No occupancy fees are paid. However, HH does pay for gas and electricity, and at Citi Field reimburses the Mets for some labor costs incurred to accommodate the use. Final note here is that we list here what long the sites have been open for, and 2 of the sites offer Moderna. Citi Field offers Pfizer. Okay. Testing sites. So we talked a few minutes ago about our mobile testing effort, and so the critical role that plays in our communities and being able to move around based on where our community-based organizations tell us we need to be. We also have, you could think of these as sort of cornerstones of our overall testing effort, our pop-up or brick and mortar sites. So all sites offer PCR testing, none have rapid molecular testing. In total, these sites have tested 580,409 patients as of November 17th. No occupancy fees are paid. However, HH does pay for electricity at only 1 site, and we would continue to operate the below sites for another year or as necessary. So I list the sites here. I'll just quickly read through them. So Bensonhurst, Midwood, Bay Ridge, Start City, Fort Hamilton, Times Square, Sorrentino Rec Centers. We have had sites at both airports, though actually we've moved mobile units there in there now. Greenbelt Recreation Center, St. George Ferry Terminal, Staten Island, and 57 Cleveland Place, also in Staten Island. Okay. So in terms of, for a little bit of background on our relationship with NYCHA. So one of the things that Test and Trace has, I think, really uniquely done compared to other cities is we've been very proactive working with NYCHA, who's been a great partner in terms of, as I like to sort of playfully say, not just bringing the vaccine to your doorstep, but literally through your doorstep. So we've been doing testing and vaccination efforts in our NYCHA developments for some time now. On the testing side, we've provided on-site testing via our mobile units and self-test teams for the past year. You can receive the resources literally at your doorstep. And this is to increase access, especially in our task force on racial inclusion and equity neighborhoods. It's been really, it can give us a really unique opportunity to really bring testing first to some of our highest need communities that otherwise might not have a whole lot of other options. We literally bring it right there to them, and I think that's kept them safe. Mobile vaccinations, similarly, we've been working with NYCHA residents starting in January of 2020. We've provided clinics at over 60 developments, and starting actually this week, we're going back and we're going to be bringing the pediatric vaccine this time to 10 developments with high concentrations of eligible children. So we have a master agreement that we are proposing to all NYCHA developments across the 5 boroughs to enable us to continue this important work that we've been doing for the past year. There's no license fee or pass-through costs associated with our use of the NYCHA space, and the proposed resolution would again extend H&H's master agreement with NYCHA through 2022. Okay, last piece of this proposal. Actually, there's a little bit more background here, and I'll get to the last piece in a moment, I promise. So in terms of a little more background on our additional testing and vaccination resources. So most of our T2 pop-up sites have been located in properties the city has lent to us. This also includes houses of worship, community groups, libraries. Only a few private owners were involved. And as I talked to you about today with our mobile fleets, our mobile fleet gives us the ability to go further into communities, into parts of communities that, again, are some of the hardest to reach, guided by our communities, for our communities. That also includes another example of this is our street health outreach and wellness program, which again is focused on some of our most vulnerable people in New York City. That all complements sort of the core here, which is our brick and mortar vaccine and testing sites, to enable us to have a reliable resource for people to come to at our brick and mortar sites. But then you can think of it as like, it's all kinds of tentacles, guided by our communities that can really reach into wherever we need to be to make sure that we're giving everybody the ability to access testing and vaccines to keep them safe. So on a sample week, just to give you a sense of volume, although honestly this week we've blown it all out of the water. In November of 2021, we conducted a total of 45,000 tests, 18,000 were at our pop-up sites that I talked about a minute ago. 27,000 were from our mobile units, show units, and our vended models described here. So it really is a nice complement in terms of how we're able to offer testing to New Yorkers. And again, now we're seeing testing levels that are the highest we've ever seen across New York City with the 4th wave here. My big takeaway from that is New Yorkers are motivated now to keep their families and communities safe for coming out to get tested. And all we want to do here is continue to offer them equitable testing as we have throughout COVID, and just to test everybody that is willing to make that small sacrifice to come to us, or to let us come to them. Final piece here is the warehouse. So at Brooklyn Army Terminal, we have a PPE warehouse. This is separate from the vaccination site that also is located at Brooklyn Army Terminal. It's a space of 56,000 square feet at no cost, located precisely in Building A, Phase 6, Unit 4.0 or 0. It's utilized as storage for PPE, equipment from decommissioned testing sites, and other T2 supplies. This is where we keep all of our equipment so that we can continue to move it around as we need to, and as we're bolstering our current sites, or thinking about additional sites that we'd want to build to keep our city safe as well. So in sum, the requester is to authorize New York City Health and Hospitals Corporation system to execute these license renewals, again, for our mass vaccination sites, our testing sites, our master agreement for NYCHA to let us continue doing that work, and the storage facility that we have at Brooklyn Army Terminal for no longer than 1 year, for a cumulative amount not to exceed 4.4 million, plus an 11% contingency of 500,000 for a total of 4.9 million. And we'd love to answer any and all questions.
Thank you. Any questions from board members?
Yeah.
Can you tell me the reason why there are no pop-up sites in the Bronx?
Good question. So in the Bronx, what we do is we have our mobile units that, again, we can move around. So in the Bronx, we move around our mobile units with our equivalent of pop-up sites being 3 hospitals and now 3 big community health centers there. So precisely in the Bronx, we have Jacoby, North Central Bronx, and Lincoln. We have I practice at Morrisania, where I'll be tomorrow, where we have our own testing venue there, our own testing site, and Belvis. So that's sort of the core there for the Bronx, and the mobile units, which we have there today, enable us to really be more nimble building off of that core. So if anybody ever asks you, where can I get tested in the Bronx, you don't have to look at our calendar to know you have those 5 sites, which are very high performers for testing. But then also we post on nyc.gov/COVID test, where in the Bronx every day, and we can go there later, where they are today and where they'll be the rest of this week. We're with all of our mobile units in the Bronx, so we move around based on input like we've talked about in the past.
Yeah. Do you feel that you're getting into those corners like of Frogs Neck, Pelham Bay in the southeast corner, and Wakefield way up in the North Bronx near the Mount Vernon border, and over in the West Bronx, Woodlawn into North Riverdale. Because those are really they're not nearest to the hospitals, they're not nearest really to the clinics either,
Right.
but they're the outer areas, so.
I think
wonder.
you just articulate exactly why it's important to have mobile units because, instead of building one location that might not be able to hit all of those corners, our mobile units can hit all of those corners. From my perspective, the most important person to ask that question to are community-based organizations in the Bronx. They're who guide us about where we should be in the Bronx, and they're who tell us which corner we need to be in this week as opposed to next week because dynamics change. So the fact that we have our mobile fleet enables us to, I think, achieve what you were just saying in a way that we couldn't if we only had brick and mortar sites.
Thank you very much.
Yep.
Thank you. Dr. Morse has her.
Yes.
My virtual hand. Hey, Ted. Thanks for the presentation. 2 quick questions. I was just wondering if you have a way that you kind of track requests from the CBOs about where they would like to see testing and how many of them are fulfilled based on those requests. And then the second question was, I was just wondering how the home testing program that's being rolled out impacts these the sites that you are describing here in the capital request or the space request.
Yeah, terrific questions. I'm actually going to see if Chris wants to take the first one. Well, not Chris. And then I'll take the second one, but the announcement we just made about an hour ago.
Hi, Michelle. So in terms of the requests, we respond to every one of them. As far as I'm aware, we have been able to respond and not just confirm, but actually attend every single request we've gotten. Now, that doesn't mean that we're going to have capacity available on 24-hour notice, 24-hour turnaround. But absolutely, we have been able to get back to everybody as they've asked us to come out and provide support to them. If anyone believes otherwise, we're happy to have the conversation and get out there very soon hereafter. We've got a very robust team that's on the field, both in terms of what we have in the field to deliver the testing, but also centrally to be able to receive those requests, to be able to process those requests, to be able to respond in a timely way. I would go on to say that almost every single request that comes in, we're back to them in a matter of hours, if not within 24 hours. We respond exceptionally quickly. We work with elected officials' offices, community-based organizations, any number of partners that come to us. We have a very, at this point, very well streamlined process that can get back to people in a very timely way.
He talks faster than I do. The other thing,
I
Michelle,
dare you to do that in Spanish.
maybe later. The other thing, Michelle, is we actually wrote a paper on this that we just published a couple weeks ago. I think we sent it around, but that looked at how we were able to leverage our relationship with CBOs and what we accomplished working with them. And actually, to me, the most important thing about that paper is it set the precedent that we can do this, and this really does work. And we've just built on that, for the last 6 months or a year since then. The other question that Michelle was asking, if I may, is this is an announcement we made about an hour and a half ago. To help to address the testing needs across all of our communities in New York City, we just announced that we have a new effort in partnership with the Department of Health, with Michelle, with Dr. Morris, Dr. Easterling, where we're going to be giving 500,000 home test kits to our community-based organizations and 1 million masks, KN95 masks to them. So right now they're directing where we're putting our mobile units. Tomorrow they're going to still do that, but they're also going to be able to hand up the tests and masks themselves to make sure that we're getting to everybody in their communities as they know best who the hardest to reach people really are. The orientation started today. Distribution starts on Monday. We're excited about this. It's going to be working with 150 community-based organizations. It's going to include all task force on racial inclusion and equity neighborhoods across New York City and all 5 boroughs.
That's great, Ted.
That's great. Any other
I
questions?
have a very quick question. Would you know about how many vaccinations were done at Citi Field in the last 2 or 3 months?
I don't know. He deserves
About 90,000. We do an average
Per month?
90,000 over the 3 months. We do about 1,000 a day right now.
And overall?
And overall, we're hitting just about 500,000 probably in a day or two here. We'll hit 500,000 doses just at Citi Field.
Right. Okay,
Which is just unbelievable.
Okay, any other questions? So let's take a vote on this. Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Morse,
Yes.
thank you. Dr. Fisher,
Yes.
Philip Wadley,
Yes.
Thank you. Scott French,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro,
Yes.
Rita Wan,
Yes.
Anita Kawatra,
Yes.
and Jose Pagani, yes. So resolution approved. Thank you so much.
Thank you. I am finished.
Take care of yourself.
Bye.
Thank you.
Good afternoon.
So, yeah.
Oh, you have to read, sorry.
So item number 7, authorizing the New York City Health and Hospitals Corporation, the system, to execute a revocable 5-year license agreement with River Renal Services, Inc., the licensee, for its continuous use and occupancy of 7,817 square feet of space to operate a renal dialysis center at NYC Health and Hospitals Bellevue at an occupancy fee rate of $68.50 per square foot, or $539,163.50 per year, to be escalated by 2.75% per year, for a total of $2,848,221.26 over the 5-year term. This was presented to the Capital Committee on December 7th.
Good afternoon, thank you. Just quickly, I'll cover an overview of dialysis services across our system. We provide outpatient dialysis ourselves at Metropolitan Harlem, Kings County, and Lincoln, and we have capacity throughout our hospital system to provide inpatient bedside dialysis when required. Newtown provides outpatient dialysis treatment at Elmhurst Hospital, which we covered in a resolution recently. And we also have agreements with Dialyze Direct for inpatient services at Kohler and Kenny. At sites where there's significant demand, dialysis services, we sometimes do partner with vendors who can scale as demand requires to increase and accommodate the needs of our patients. Next slide, I'm going to hand it over to my colleague, Mr. Bill Hicks, our CEO of Bellevue Hospital. Bill?
Thank you, Christine, and good to see everybody again. Thanks for the opportunity to present this agreement today. For clarity, this resolution has 2 components. The first is a space licensing agreement renewal for a separate Article 28 on the 5th floor as an outpatient chronic hemodialysis service at Bellevue. And second is a service agreement to provide acute inpatient hemodialysis on a 6-bedded unit adjacent to that 18-bedded unit I just mentioned. And I'd just like to add that River Renal has been an extraordinary partner to many of our COVID surges of recent. So on this slide here to your right, you can see an image of one of our modules, River Renal. And so this is our Article 28 unit there. And we run 3 sessions per day on this unit. Chairs in this unit. And so on the inpatient side, we have, next slide, please. On the inpatient, we have 6 dialysis stations, which provide dialysis services to our inpatient population, and that's located on the 5th floor, as I mentioned. River Renal provides the nurses for inpatient dialysis treatments under the medical supervision of our physicians at Bellevue. And River Renal also provides the water and equipment management services for chlorine and chloramine testing, so the reverse osmosis systems. So I'll try to summarize a slide here by saying that the agreement has been in effect since 2011. The last time we came to the Board of Directors for approval was in 2016. Our outpatient services are open Monday through Saturday, 7 a.m. to 6 p.m. And as I mentioned, 3 sessions a day. We average about 197 treatments weekly, and we can easily meet capacity here, probably have an additional capacity of about 20%. On the inpatient side, available 24/7, Monday through Saturday, and on call on Sundays. We manage that, averaging about 11 per day, and anywhere from 4 to 8 patients we do bedside per day. And Bellevue bills for the third-party payers for inpatient treatments provided by River Renal, and River Renal bills for the services that are provided in their outpatient chronic hemodialysis service here. We pay an established Medicaid rate for treatments for patients who could not be enrolled in insurance, and I want to say, looking back on our records here, it's a very uncommon occurrence here. So these patients were able to secure support for, and so that's really good. And so we have capacity also on the inpatient side, I might add. Back to you, Christine.
Sure. The terms of the license agreement include the 7,817 square feet on that 5th floor in the H building at a rate of $68.50 per square foot for the total of $539,000 and change per year. This rate is set at fair market value for the space, and this is the rate is payable by Renal with an expiring license of $65.76 per square foot. Is a 4% increase from the current rate. The occupancy fee will be escalated 2.75% per year over the 5-year term for a total occupancy fee over the 5-year term of $2,848,221.26. Bellevue here does provide the hot, the cold, the electricity, the heat, because it's really interstitial space inside of this much larger tower at Bellevue. River Renal does provide housekeeping and red bag waste disposal, however, for their operation. The last slide is the resolution. We're happy to take any questions.
Thank you so much. Sally?
Yes, Christine, thank you very much for the dialysis across the system overview. That was extremely helpful. I think it would be useful as a next step, I guess, for the clinical folks to, or whoever's appropriate, to look, to try to examine what the need is, given that we have a vulnerable patient population, so that we can look at what we have and make some judgment about what enhanced capacity might be needed. And obviously there are capital and expense cost implications, but at some point it would be useful to take a deeper look at the issue of the need for this kind of treatment throughout the system. Unless we've done it, have we done it?
We actually did a pretty thorough investigation and proposal. I'll sit next to Chris. So Sally, I can get that proposal to you. I don't have it at my fingertips.
Sure.
We did a full evaluation across the system, what we thought our dialysis needs would be, especially with long COVID and the sequelae of renal disease subsequent to COVID. We had a multidisciplinary group, including post-acute, the acute. Christine, of course, our leads in nephrology, and if you're interested, I can get.
Yeah, I'd love to
you.
see that. I'd love to see that. Thank you.
Thank you. Any other questions? Okay, so let me then take a vote. Dr. Katz? Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Morse?
Yes.
Dr. Fisher?
Yes.
Philip Wadley?
Yes.
Scott French?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pineda?
Yes.
Rita Wang?
Yes.
Anita Kawatra?
Yes.
Jose Pagani, yes. Resolution passes. Thank you
Thank
so
you.
much,
Happy
Christine.
Happy
Uh,
holidays.
And Bill, thank you so much.
Great holiday, everyone.
Yeah. So we have 2 more resolutions. So,
Right.
Sally?
Before reading the next resolution, I just want to say that the Metro Plus Health Board of Directors approved this resolution on December 14th, 2021. The resolution is authorizing the Executive Director of Metro Plus Health Plan to enter into a best interest extension of the contracts with Caremark PCS Health LLC, a Delaware limited liability company, Caremark, to provide pharmacy benefit management and pharmacy network services. The plan seeks to extend the contract for Medicaid line of businesses by 12 months from the current end date of December 31, 2021 to the new end date, December 31, 2022, for an amount not to exceed $889,891, and to extend the contract for non-Medicare lines of business for 4 months from the current end date of August 31st, 2022 to the new end date of December 31, 2022 for an amount not to exceed $4,854,112. For the overall not to exceed the amount of $5,743,3 for 2022. Okay, Dr. Shah will be presenting.
Good afternoon, everyone. As Sally said, this is a best interest extension for the pharmacy benefit manager, or PBM, with the current vendor Caremark. Caremark was awarded the contract through an RFP process in 2016. And with these extensions, 1 year in Medicare and 4 months in non-Medicare, both contracts would end on December 31st of 2022. And as Sally's mentioned, the board approved this resolution 2 days ago. Other than the extension allowing both contracts to end at the end of next year, the plan is currently seeking and selecting a pharmacy benefit manager through an RFP process. And the contract extension will really provide sufficient time to competitively procure and successfully implement this new PBM contract with an effective date of 1/1 of 2023. As you can imagine, selecting a PBM is an involved and complex process that's underway. We hope to select the PBM by spring of 2022, and it's a pretty involved contracting process, so it will take another 3 months. And then the implementation will take an additional 6 months, which will bring us to the end of 2022. Caremark, the current incumbent, has been an effective pharmacy benefit manager working in a fairly complex regulatory environment. Also, as pointed out on this slide, from a customer satisfaction standpoint, it's performed well with good outcomes with MetroPlus membership, as outlined on the penultimate bullet on this slide. On the next page, I just want to point out in terms of further documenting an evaluation process, Caremark has done a very good job on most of those levels, and we are pleased with its current performance. In terms of the administrative expenses that Sally outlined and what we're requesting, this next slide shows you that other than paying for the drugs themselves, the administrative expenses are actually outlined in the italicized words there and bullets, providing the network itself, the pharmacy network, the call center, all utilization management services, the clinical programs that lead to outreach and for medication adherence, adjudicating all claims and all reporting functions. As such, over 99% of the administrative spend is self-performed by Caremark in its in-house administrative functions by Caremark employees. And as a result, a 30% MWB waiver was approved. On the next slide, I just want to point out that the Caremark employees, they are based on 2020 analysis, 70% are women and 43% are minorities. Happy to answer any questions you may have.
Thank you. Any questions from board members? Okay, great. So let me then take a vote. In 1 second. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Morse?
Yes.
Dr. Fisher?
Yes.
Philip Wadley?
Yes.
Scott French?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Rita Wan?
Yes.
Anita Kawatra? Yeah. And Jose Pagan, yes. So resolution passes. Thank you so much.
Thank you very much.
Thank you.
Hey, Jose, I had a technical difficulty, but I'm a yes too.
Thank you, Anita. Okay, so.
Okay, before reading the next resolution, I'll also note that the MetroPlus Health Board of Directors approved the resolution on December 14, 2021. Resolution reads authorizing the Executive Director of MetroPlus to execute a contract with Change Healthcare to provide risk adjustment services for a term of 3 years with 2 one-year options to renew, solely exercisable by MetroPlus for an amount not to exceed $20,185,000 for the total 5-year term. Dr. Presenting Lauren. Hey,
Yes.
Lauren. Okay.
Good afternoon. My name is Lauren Leverett-Tristaldo. I'm the Chief Financial Officer of Metro Plus Health Plan. Metro Plus Health is looking to enhance the ability of the plan to perform risk adjustment related activities. This ensures the accurate and complete capture of diagnosis coding for our population. These services are necessary to ensure that our premiums for our Medicaid, Essential Plan, HARP, lines of business are documented appropriately, and the medical expenses are confirmed by pertinent member diagnosis, are captured and then submitted to CMS and DOH respectively. Historically, there has been 2 contracts, one for Medicare and one for our Medicaid and ACA products. These contracts are set to expire at the end of this calendar year, and one starting at the first of calendar year 2022. This also was approved by our board of directors in December 14th. Next slide. Change Healthcare was evaluated most favorably by the committee and was the only proposer to produce an MWBE utilization plan. Our minimum criteria was coding activities performed by certified coders under peer review, 3 years experience performing risk-related activities within New York City, and an MWBE utilization plan waiver or MWBE certification. There are 2 product offerings we are looking to procure. One is a risk analytics platform. This provides us member-level detail on the risk scores and risk gaps for all of our members within the Medicaid, HARP, Essential Plan, Medicare, and QHP lines of business. This platform will be updated monthly, and once a year, our chart case list will be generated for each line of business based on those risk gaps. The second item is a risk coding. This will allow us to collect medical records and document upon a validation of review and complete coding. The updates will be sent back to the plan and submitted to CMS and DOH respectively. There is a savings on this contract. Just wanted to note through the consolidation down to 1, we will be saving the system through year 1 a total of $1.8 million and therefore annually. The vendor that has been procured is Change Healthcare. They have been in service for over 20 years. We had reference calls with Affinity Health Plan and the Health Plan Alliance. We also had a reference call with New York City Health and Hospitals, who also uses Change Healthcare, and all have provided favorable feedback. Change Healthcare has proposed to submit a utilization plan of the total $20.1 million being requested. 10% or $2 million of that contract has been committed to Tyrula LLC, which has applied to New York State as an MBE or WBE and does meet criteria for approval. And the last slide is the board of directors approval request. I will take any questions.
Thank you. Any questions from board members?
One question, Lauren. You referenced the savings, so it's $1.8 million annually from consolidating into 2. What drives that savings?
So it's just the cost of the contract. So we had 2 separate contracts doing different lines of business for the same activity. Consolidating them into 1 allows us to have a more efficient process and only have to procure 1 technology platform, and that is driving the savings.
Great.
Okay, so let me then ask for the vote. And Dr. Katz,
Yes.
Dr. Calamia, Dr. Morse,
Yes.
Dr. Fisher,
Yes.
Philip Wadley,
Yes.
Scott French,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Pinheiro,
Yes.
Rita Wan,
Yes.
Anita Kawatra.
Yes.
Thank you, and Jose Pagan, yes. Thank you so much.
Thank you very much.
So the resolution is approved. Let's move now to the president's report, Dr. Katz.
Yes, thank you so much. So certainly, the most challenging issue before us is the fourth wave of COVID. Um, while the numbers of patients in our hospital with COVID are nowhere near they were in past, especially in the first wave, we're also having many patients who are at our hospitals because of delayed care. So our hospitals started quite full. And so even much smaller influxes of COVID patients are causing us challenges in terms of the ability of maintaining sufficient staffing and having room. Contacted the state already, and I'm hoping they will allow us easier level loading across our facilities. That's a tried and true method that we've used since all our hospitals are not evenly affected by COVID. There is a huge amount of concern, appropriately, about Omicron. There's still a huge amount we don't know. What we do know is that it is markedly more contagious than Delta. The most important question is, but is it as lethal? Does it make patients, especially vaccinated patients, does it make them very sick? Does it cause ICU admissions? Does it cause people to be on ventilators? Does it cause deaths? And in what numbers? At least some of the data suggests that vaccinated people are getting sick, but not very sick. They're not needing ventilators and ICU care. But the next couple of weeks will be incredibly critical for seeing that through. I'm not going to read the rest of the report, but I am going to read into the record that I've approved one contract extension given its time sensitivity. It's an exception to further extend our contract with LaGuardia Associates LP for the rental of the LaGuardia Plaza Hotel as part of the COVID-19 isolation program. I had originally approved this contract under the NYC Health and Hospitals COVID emergency declaration in April 2020, was subsequently extended through December 31st, 2021. Given the increase in COVID cases and the need to continue helping New Yorkers who test positive for the virus to find a safe place to isolate to protect their loved ones, I've approved an extension through June 30th, 2022. The extension includes a provision to terminate after January 31st, 2022 if the hotel is no longer needed. Cost for the 6-month extension will not exceed $7,050,067. Funding for the hotel continues to be provided through the City of New York. With that, I'm happy to answer any questions or take your suggestions at this difficult moment of our history.
Thank you, Dr. Katz. Any questions from board members? Dr. Morse.
Hey there. Yeah, thank you so much, Dr. Katz, for that report and summary, and couldn't agree more with the concerns and threats around Omicron. I was reading the publication that your team put out a couple of months ago around the impact of surges on mortality across the ICUs, across the health and hospital system, which, you know, again, I thought was really incredibly well done and very brave and very important to publish and make publicly accessible. And I was just curious, as we're heading into the winter, if you are thinking about or are considering any other options around load balancing. So, you know, a state coordinated mechanism, for example, or any other kind of citywide coordination mechanisms. I'm just curious how you're thinking about that heading into this winter.
Sure. Well, level loading in our own system is certainly, you know, the first thing that we've always done. And it's helped by having an electronic health record within the system. Sorry, I'm a bit ill myself, so, but not with COVID. You'll excuse my voice. We're doing discharges now of patients who don't need to be in the hospital. We're trying to get them into other kinds of facilities since that opens additional beds. We're doing additional hiring of nurses through the registry, as well as overtime for our existing nurses. I don't think at the moment there's much capability to level load across the state. Certainly, Western New York, as you know, Dr. Morse, is actually worse off than we are at the moment. You know, we'll certainly work within New York City, but typically, including in the worst times of COVID in March 2020, in terms of capability, we're kind of in the middle. You know, we're as likely to need to take patients from some of the independent hospitals that are single system hospitals or two system hospitals who therefore cannot level load as we are to send patients to other hospitals within New York City. A final note is that a fair number of the private systems have been taking patients from upstate New York. I mean, New York City has always been a mecca for medical care. And so there are a fair number of transfers that are happening now because as challenging as the situation is in New York City, it's way better than it is in upstate New York and many other parts of the country. So I'm just praying that as long as it's medical surgical care, we're going to be okay. It's really the ICU level care that so pulls at your resources because of the need for nursing of one nurse to two patients and other intensivist equipment. So we're pulling out all the things that we found worked, and you know, we'll get through this, but it is a difficult moment for us.
Thank you.
Go ahead.
Mitch, you did say that we're quite full just from delayed care and other critical needs. Is that in the ICU or is that, so our ICUs are quite full? Is that?
No, we're actually afraid having more trouble with med surge at the moment. Okay. And that's partially because, and this is a good thing, that the patients we're admitting right now with COVID mostly are not intensive care, not needing a ventilator, but needing oxygen support. But the census of our hospitals very high. Bellevue, Elmhurst, Queens, and Coney are right now the ones that are the highest in terms of census.
And what about staff and how they're, and sorry you're sick, Mitch, I hope you feel better.
Thank you, I appreciate it.
But the staff, how are they, besides the shortage, just, you know, there's another wave coming again and
It's, I mean, it's very difficult. People are, you know, and this is not unique to health and hospitals and not unique to New York. People are tired. It's, you know, this is now 22 months. There was a lot of, you know, optimism about, you know, holidays coming up. The last week of December is always difficult to staff in the best of circumstances. But on the other hand, health and hospitals is full of committed professionals. People will do what they need to do. They always have. And we do have enough PPE. So, you know, that's a crisis we do not have to go through again. We do not have any concerns about that. We have enough of all types. We have enough ventilators. So at least we don't have the horrible, you know, are we going to run out of N95 masks? We're not. We're fine on all supplies. But people are tired. People are discouraged. The next few weeks will, as much as anything, be about maintaining morale and making sure that people understand how heroic their work is and the lives that are being saved. And humans are, are very adaptable species, and we will learn to adapt to COVID too. But perhaps we're not quite there yet.
Okay, any other questions for Dr. Katz? Or comments? Well, Dr. Katz, thank you so much. I hope you feel better soon.
Thank you.
So let me move on to committee reports. The committee reports were emailed to you and are in your folders for your review and submission into the record. Is there any old or new business to come before this board?
I just wanted to thank Colicia and Carlotta, Jenny, and Tiffany in absentia for the wonderful work that you did David, for the wonderful work you did putting together that lovely Christmas luncheon for the board. Thank you.
Absolutely. Yeah.
And I'll say that it has been a very difficult year for everyone, but I hope that you stay safe and enjoy the holidays. And it's great to see all of you virtually, in person, either way. Thank you for all the work you do on behalf of our hospital system and the city. So if there's no further business, then I declare the NYC Health and Hospitals Corporation Board meeting adjourned. Thank you and happy holidays.
Thank you very much. Happy holidays to all.
Bye.
Thank you all. Everyone. Happy holidays.
Bye. Bye.
Great job.
Yeah.
Another year.